So agitation. So usually, here's what's gonna happen. Usually you're gonna get paged by the nurse. Usually what's gonna happen is that you're gonna be going about your day, and you're gonna get this page that patient X is agitated or is fighting or something, and this usually happens on the floor. Okay, so when you see patients who are agitated, you really wanna go and assess the patient, right? So you're gonna assess the patient, and really what you wanna assess for is few things. First of all, you wanna assess if they have altered mental status, okay? And you wanna assess if this is a change from their baseline. Because if there is a change from the baseline, okay, let's say this is altered mental status, what are the things you should be thinking about? If it's acute altered mental status.
Okay, maybe patient is septic.
Septic, okay? Remember, this is always our rule of thumb, okay? Any change of clinical status is sepsis until proven otherwise. So you really have to think about sepsis, okay? The other thing that is less common, that is less likely to occur, is a stroke. It's unlikely that a stroke can cause you to have only altered mental status, but that's why you need to do a neuro exam, okay? And for sepsis, just have a low threshold to call it sepsis, because what's the harm in getting blood cultures, giving antibiotics? There's no harm, and if you got it right, you might have saved the patient's life, okay? But for all intents and purposes, let's say the patient does not have sepsis and is not having a stroke, and he's just an old person, high age, who has an infection, has a UTI maybe, and been in the hospital, prolonged hospital stay. So what are these risk factors for what? These things.
For delirium.
For delirium, right? So this is essentially, this is usually is what's going on. Is the patient is having delirium. Usually this happens when it's like midnight. Patient wakes up in the middle of the night. They don't know where they are. It's like in totally new environment. They think they're home. They're not really home. So that happens. Okay. So when you diagnose the delirium, what is the best therapy? What is the initial therapy, the first line management of delirium? It's reorientation, okay? So you need to reorient the patient. So you want to talk to the patient, you want to reorient them, you want to tell them, hey, you're in the hospital, this is what's happening, okay? So essentially, conservative management. Now, it works sometimes, but a lot of the time it doesn't really work, okay? And so if it doesn't work, then you have few options, okay, in terms of medications. Now, the few options in terms of medications, I'll give you the few options for agitation, and then we're going to talk about it one by one, okay? About what can you give and what can't you give, okay? So, number one is lorazepam, okay? We talked about it with alcohol withdrawal. Again, Ativan. Okay, so that's number one, and what you can do is you can give like 0.5 or 1 milligram PO, IV, IM, whatever, okay? Number two, you have diphenhydramine. You know what's diphenhydramine? There's another name for it called Benadryl. Okay? You know what this guy is?
Yeah, antihistamine.
Antihistamine, right? So it's kind of a sedating agent, okay? And you can give like 50 milligrams, again, PO, IV, or even IM sometimes, okay? Then you have haloperidol, which is called Haldol. And this one, you can give anywhere from 0.5 to massive doses to like 50. And again, you can give it PO, IV, or even IM, okay? Which is what's haloperidol? It's a typical antipsychotic, right? The other antipsychotics that you can give is quetiapine, okay? And again, you should know Unfortunately, you need to know the trade names. This one is called Seroquel. Okay, and this usually comes in a PO form only. And then finally, there is olanzapine, which is quetiapine and olanzapine are atypical antipsychotics. Olanzapine, the name for it is Zyprexa. Okay, and what's nice about olanzapine is there's a sublingual form, and you can give it under the tongue essentially, and it works pretty quickly. So you've got the benzo, you've got the antihistamine, and then you've got the antipsychotics, right? So benzo, H1 blocker, and then antipsychotics. So which one do we give? Which one do we not give? What do you think? So all of these will sedate the patient. All of these will kind of calm the patient down. What do you think about benzo?
I would avoid them.
Avoid benzo, right? So benzo is a no-no. Diphenhydramine, same, no-no. Both of these things, they worsen delirium. Okay? So avoid benzos and avoid antihistamines in this setting. Okay? Antipsychotics is really the way to go. And again, this is a preference thing. My antipsychotic of choice is haloperidol. I would say it's probably the safest and the best one to use. And what I usually do is I give the lowest dose possible, and then I can give more if needed. And you can give IM or IV, okay? Now, you can give quetiapine or you can give Zyprexa, depending on the patient. But what do you need to check before you give these medications? Any antipsychotic in general, but specifically olanzapine or quetiapine. What do you think? There's a side effect that you should be aware of. Remember, QTC, QT prolongation. All of them do prolong QT, but the most one that prolongs QT is olanzapine. Haloperidol has the least effect on QT. Okay, so it's important for you to remember. So always check an EKG before you give before antipsychotics. Okay, and what's the magic number you want the QTC to be less than what?
440.
400. Okay. Now I have a trick for you guys. So let's say this is the EKG. Okay. And this is kind of the two R waves. Okay. The trick is the following: is if you have, this is the R wave and this is the other R wave. Okay. And what you do is you create so this is the distance between the two R waves. You take the middle of this distance, and if the T wave is before this middle, you're good. If the T wave is on this side, it's high. Okay? This is like a quick trick. So this is high QT. This is normal. If the T wave, you look at the T wave. Okay? So just quickly, when you look at the EKG, I mean, you're going to read it. It's going to be there. It's measured for you. But like if it's not measured for some reason, you can just take the distance, the mid distance between the RR. Okay? The other thing you want to check for is that these patients might be on some other medications that also prolong QTC. Okay? Other medications might be like, azithro, the atypical antibiotics, levofloxacin will increase the QTC, so you want to make sure of that. And then hydroxychloroquine. Okay, these will increase the QTC. So be careful when somebody is taking those. The other thing, by the way, the other thing you might miss if patient is agitated is it could be delirium, but also they could be taking benzos at home. So check if they're taking benzos at home, then they might have, benzodiazepine withdrawal, which is similar to alcohol withdrawal. And in this setting, you give benzos. Okay? So this is very important. And then finally, you might get called for a patient who's really agitated, like agitated to the point where they called security and they're calling like the psych people to come and see the patient. This patient, they need to calm down, stat. So you need to give them a medication to calm them down. And in that setting, really, you can't just give them a little bit of haloperidol. You need to kind of big guns. You need to go like all in. And what you can give them is a combo IV, usually not IV, sorry, IM medications. And so what you can give them is a combination of 0.5 milligram of Ativan, of lorazepam, plus 50 milligrams of Benadryl, which is diphenhydramine, plus 5 milligrams of Haldol, of haloperidol. And this can be given IM. So this is only for like super agitated patient. Think, called security because of him. So this is kind of a combo that you can give, and it's usually psych residents. If you have psych residents, they will show up to the code. Sometimes they call it a code white or something, and they administer it, or they tell the nurse to give it.